Thank you. Still nothing to declare or disclose. Have not bought any stocks over the lunch break. Sydenham chorea is now accepted as one of the autoimmune encephalitides. I was so grateful to hear this morning's presentation and have you see the slides, because I didn't get them in, on Russell Dale's work considering this to be a post-streptococcal striatal autoimmune encephalitis. What has been demonstrated in a number of studies is that cross-reactive antibodies are capable of producing inflammation of the basal ganglia. And as you've already seen, the jumping mouse, the animal models can show that passive transfer of those antibodies produces symptoms. And finally, that immunomodulatory therapies such as IVIG and plasmapheresis can produce rapid and long-lasting symptom resolution. The treatment trial for Sydenham chorea, the only controlled trial, was actually done by our group, and Marjorie Garvey is the first author on that. In that trial, it was a trial of steroids versus plasmapheresis versus IVIG, and as might be expected, all three did work. Plasmapheresis appeared to have the best and most rapid symptom improvement. The IVIG was sort of intermediate with the steroids. Steroids' effects were at best modest, and definitely there was relapse when the steroids were withdrawn. And I wanted to just show this slide again to remind us what group of patients we're talking about. So for pandas, our prototype disorder is Sydenham chorea. We talked this morning about sort of it might be considered as a form fruste or maybe just an alternate manifestation. I think as we learn more about what the antibodies are, it probably is its own unique entity. And you heard from Dr. Mink how the patients don't present the same. So a Sydenham chorea patient does have psychiatric disabilities, but they are not the most prominent and featuring symptom, in contrast to our pandas group. I wanted to remind you, though, because I forgot to say it this morning, that the pandas was always known to be only one of the infectious triggers of acute onset obsessive compulsive disorder. And in fact, the first paper we published was actually infection-triggered cases that occurred after influenza, after varicella or chickenpox, as well as after strep. And we focused in on that strep group in large part because we were looking for a homogeneous group of patients that we could then study and learn more about the etiology and pathophysiology of the larger group of patients with OCD and tic disorders. Other infectious triggers have been claimed. Just chatting about mycoplasma, and Dr. Murphy's going to go into more depth on that. H1N1, when there was the very specific epidemic of H1N1 influenza, that was a major trigger of PANS symptomatology. But other things have been claimed, and it's not as clear that those are causative, and most specifically Lyme. So the rickettsia that causes Lyme disease is a rickettsia like the spirochete of syphilis. It has a course of illness that changes over time, so that in acute illness with Lyme, you have one presentation. With a chronic illness, you have a second presentation. The key there being the word chronic. So for the claims that you could have an acute onset neuropsychiatric symptom as a presenting symptom of Lyme, I would say, prove it to me. Right now, what I think you have is a true unrelated. You have a child who has perhaps got antibodies against Lyme, and they have an acute onset neuropsychiatric symptom, but making the assumption that those two come together is not as appropriate, and I think we need large-scale prospective studies to look at that. The reason I'm so skeptical on this is when you read Brian Fallon's work on Lyme-associated obsessive compulsive disorder, it presents with a semi-acute course, and the comorbidity is anxiety and depression. It's not the movement disorders, the very specific separation anxiety and all the rest. So I'm willing to entertain that as a possibility, but it requires a lot more evidence, and definitely treating a child who meets PANDAS criteria for Lyme, or a non-specific viral infection, non-specific fungal infection, Again, let's remember we're physicians and we want to first do no harm, and that our treatments need to have at least some empiric basis. Okay, having said all of that, what is our evidence that at least the PANDAS group may be a manifestation of autoimmune encephalitis? Well, the clinical evidence, as you heard this morning, is actually the place that you start. What it is about this syndrome of PANS or PANDAS that makes you think it might be a manifestation of an autoimmune inflammation of the brain. Certainly the fact that multiple symptoms across the cognitive, behavioral, and emotional domain, and even the motor domain, are presenting at the same time is evidence that you have an encephalopathic process at work. Those things don't just happen because of a genetic disorder and the rest. For us, one of the things that was really crucial was Mirko Vasevich's observation of this terror-stricken look in mydriasis, and we actually started looking at sympathetic tone in these children and discovered that in the early course of illness, there are abnormalities that may help us to think more thoughtfully, be more thoughtful in our approach about where the pathology lies. Urinary frequency, urgency, and enuresis, to me, this is a pathognomonic symptom of the PANS group. It just doesn't happen in other things. We talked this morning about sleep problems in a child with anxiety, and children with anxiety disorders do often feel like they have to go to the bathroom more. Their parents may notice that. They also have more concerns that they might wet the bed, but they don't go from having a perfectly normal urinary pattern to having to go every 5, 10, 15 minutes, and at the age of 10, starting to wet their bed again. So physiologically or pathophysiologically, it actually makes a lot of sense because micturition, or the process of urination, is controlled by the external sphincter and the internal sphincter. And the external sphincter is voluntary, whereas the internal sphincter is an involuntary muscle that's partially under serotonergic control. If that one is failed, then all of the urinary control happens on the external, and what you get is this feeling of urgency. So they go and they feel like they have to go again just a minute or two later. The sleep problems, I think, are also one of the signs that points you in the direction of this. And then finally, the sensory hypersensitivity and insensitivities. We need to write an article about this. These children look like our kids with measles. They have a very abrupt onset of photosensitivity, hyperacusis, and their sensory abnormalities are really quite remarkable. So again, it's not just OCD or tics, it's a constellation of symptoms. The handwriting changes, might have shown you this one this morning. If I did, I apologize for not making the point that these were actually drawn at different points in time, and that at the time when his handwriting deteriorates so markedly, the comments from his teachers are he needs to spend more time working on his homework. She thought he was rushing through his work and just writing very sloppily, but in actual fact, to do that very messy right-hand panel had taken him over an hour. Unusual margin drift, we need to investigate this more. This was an observation from my dear friend and colleague Tanya Murphy, that the children in the acute episodes of PANDAS will stop bringing their work to the left-hand margin, just as the teacher notes there. How about starting your sentence at the red margin? You know how you're supposed to line it up so nicely? They didn't, and I think we don't know yet, but it would be really interesting to do the clock test and some of the other visual spatial skills assessments. Behavioral regression can be quite dramatic in these patients, and I mentioned this morning the 10-year-old boy who was playing with baby toys and talking baby talk. This picture looks like it was drawn by a 4-year-old. It was drawn in June, and here's what she actually was capable of. It was a 10-year-old girl who during her acute illness had a very dramatic behavioral regression as well as the motoric deficits. Tanya Murphy has taken this into a more systematic and thoughtful assessment by administering the Ray Osterrich's complex figure. Typically, this figure is used to test working memory, and so the people are asked to copy it, and then 5 minutes later, they're asked to reconstruct it from memory. But in actual fact, The children with pandas can't copy it appropriately. They just are not seeing things the same way. And unfortunately, that can be a lingering symptom. Our adult patients with OCD of early childhood onset complain of visual spatial skills deficits. They're not able to read maps and orient themselves from maps, and this may be a partial reason why. B.J. Casey is a neuropsychologist who's now at Cornell. When she was at the NIMH, she was doing studies on children with Tourette's, children with ADHD, and we asked her to test our kids with pandas as well as those with Sydenham chorea, and she found a specific pattern of deficits on the response selection task, which instead of saying 1, 2, 3, 4 on a button press, it's 2, 3, 4, 1, and you have to both excite and inhibit at the same time. It's a very complex task of executive function of the thought to be related to basal ganglia function. And the children with pandas and Sydenham chorea had deficits on that task that they did not have on the stimulus selection or the response execution task. And if you'll look at the Tourette syndrome and the ADHD, the patterns were very different. So again, going back to the talk this morning, this is another piece of evidence that there are meaningful clinical differences between a patient with pandas and a patient with garden variety Tourette's, ADHD, and certainly OCD. Choreiform movements, I think I did put the videos in. I'm going to share them now, but I think it's something that perhaps Dr. Mink can help us think about in the discussion at the end of the afternoon, and that is how clinically these can be used. I've shared with you that they're present in 98% of patients. We use the definition of Towin from 1984, in which they're fine piano playing movements on stressed exam. And this plays, oops, take you over to patient. This is a boy who actually has Sydenham chorea, and you see that he's got a lot of movements of his hands. He's trying to hold still. He actually smiled when he was supposed to be holding his face still. This young boy does not have Sydenham chorea, but he has quite a bit of distal instability and a couple of piano playing movements there with his fingers. Face is quite still, body is quite still, and he had absolutely no abnormalities on other parts of his neuro exam. This is the way it should look after the age of 6. And sometimes I get asked about choreiform movements. There's really no point in doing them on a 3, 4, 5-year-old because it's normal to have mild movements in a very young child. But certainly by the age of 8 or 9, they should be able to stand in the Romberg stance, their hands extended and be nice and still, like this young lady is. Let's see if we can just go forward for a minute. The ones I love, and I hope I have, he's in here. I think it's 24. This is one I actually want to discuss with Dr. Mink and maybe Dr. Schlager and our neurologist here and help us decide which category to put him in. He definitely didn't have any interference from involuntary movements, so we ended up calling him choreiform, but he's pretty wiggly. Nope, it's not this one. I just wanted to show you our favorite patients are those with hemichorea, because then you can use one side of the body and compare it against the other side. And I'll have to find them later. But those, I can make the diagnosis as a pediatrician. So clinical evidence, maybe clinical evidence is a little too strong. Clinical suggestions of autoimmune encephalitis. The biological evidence or suggestions of autoimmune encephalitis I've been hinting at all day, and I was looking and looking during the lunch break for the actual tracings off of the EEG and couldn't find them. So when we post the PDFs of the slides, I'll make sure that those get in there. But what we had was every child participating in our IVIG trial, as well as children participating in the natural history evaluation of neuropsychiatric disorders, underwent an EEG, and 12 of them had a polysomnography as well. 42 children met criteria for pandas and were acutely ill. That's why they were enrolled in our IVIG trial, and EEG abnormalities were present in 7 or 17%, with sharp wave epileptiform discharges in 4 and nonspecific diffuse or focal slowing in 3. I went back and looked at our Sydenham-Korea EEGs, and in the Sydenham-Korea population, approximately 10% of those children had slowing, particularly in the parietal region. So I think that that is at least suggestive of a direct encephalopathic process. The polysomnography, those sleep disturbances can be extreme, and just as in autoimmune encephalitis, in extremely ill patients, they are unable to sleep without administration of very strong sedative agents. In some of our PANDAS patients, the same kind of picture has emerged. And in these 12 children, PSG abnormalities were present in 10, or 83%, with non-REM parasomnias in 3 of the children, periodic limb movements of sleep in 3, despite normal ferritin and all the things that you would evaluate for PLMS. REM behavior disorder in 4, where they were actually flailing about, acting out in their REM sleep phase, and non-specific REM motor disinhibition in 6. Those 6 didn't meet full criteria for RBD, but did have characteristics similar to that. I think the exciting thing about these results, at least as interpreted for me by Ashura Buckley, the woman who's done all of this research, is that these sleep abnormalities of sleep architecture actually have been well researched in animal models and suggest that alternative treatments might be useful for some of these patients, as we could really address more directly what the underlying pathophysiology is by looking at their sleep. We've already talked about the changes present on PET exams. And then I just wanted to mention laboratory findings again. A reminder that for the PANDAS subgroup, you need to have evidence of a current or previous strep infection as the inciting trigger on the first episode. And Dr. Cunningham could share with you the literature on rheumatic fever that very clearly shows, once sensitized, that viral infections and other triggers can provoke symptomatology. Only ones that we can control are strep infections, which can be prophylaxed against. Positive ANAs in 40 to 50% of the patients. Caveat here is that 10% of perfectly healthy children, no tics present on exam, will also have a positive ANA. Among adolescents and young adults, it gets up to 15 to 20%. So a positive ANA in and of itself is not anything other than a suggestive marker. However, some new data from our lab and from Jenny Frankovic at Stanford University suggests that perhaps HLA subtypes will be, and we're working on the data analyses right now. So all I can share with you today is to stay tuned. We are very hopeful that, like HLA-B27 is sort of pathognomonic for ankylosing spondylitis, that HLA-B51 and HLA-B52, as well as one of the subclasses of HLA-DRW, are very much overrepresented in the PANS population and may be an explanation for their vulnerability. Cross-reactive antibodies need to be present in high titers. I was thinking during the lovely talk this morning about when you find the antibodies, what a relief it is, because there's so many of the patients that end up with an antibody-negative autoimmune encephalitis, and those were left wondering what's going on. I think that the PANDAS antibody panel that you heard about from Dr. Cunningham is very helpful, but it too is sort of a secondary markers and not primary, and to address the fact that we don't actually know exactly what these antibodies are cross-reacting with, we are sharing our blood and CSF with Angela Vincent at King's College in London, as well as Avi Nath, who's the clinical director of the National Institute of Neurologic Disorders and Stroke. The two of them are using very different methods to go after this, but my hope is that since they're starting agnostically, and just as anti-NMDA was discovered sort of by looking what was being reacted with in the brain, we're doing the same thing with our PANDAS patients. Meanwhile, we do have the Cunningham panel, which I'll just remind you that there were striking differences in the staining and the reactivity of the sera and CSF from patients with Sydenham-Chorea and PANDAS versus those with non-PANDAS, Tourette's, and OCD. that the anti-lysoganglioside and the other antibodies actually decreased during convalescence. That's one of the requirements of assuming that your antibody is pathologic, and that they appeared to have bioactivity. It's kind of neat the way this sorted out, because even though there are patients with pandas that fall below that cutoff of 140, none of the controls are higher than that. So when you set that as your cutoff point, you can be quite sure that when it's a positive, that it's not just a random finding. All right, going back to our model, let's just think about each of the steps and what has to go wrong for the children. Only specific strains of group A strep. There he is. Mike Cooperstock's help, as well as other members of the consortium, were working really hard to find strep from acutely ill children with pandas. One of the problems is by the time they get through our fence to the ivory tower, they've been sick so long the strep's been gone for many, many months. We're working with CVS Minute Clinics to collect them in our Washington, D.C. area because we've had an outbreak of pandas and rheumatic fever there. But in the meantime, we have to assume that it's like rheumatic fever, that it's only those strep that have mutated to be more like their host and actually less virulent, so less likely to present with a strep pharyngitis that produced this illness. The genetically susceptible host, I told you about the HLA susceptibility. That would be a direct marker of immune function. In the glory days of the 1990s, we actually had a monoclonal antibody, as you heard about from Dr. Cunningham. This one was labeled D817, and it had almost perfect specificity and sensitivity for separating pandas, Sydenham chorea, and rheumatic fever patients and their first-degree relatives from healthy controls. Unfortunately, that clone was lost, but I just found out from Dr. Fischetti at the Rockefeller that he may be able to test this, so it's another thing that we're going to do, because it would be a lovely test of trait susceptibility. I won't flip through the slides and give you a seizure, but I don't want you to forget that all of the antibody tests are only state markers. So if you test a child, you don't know any more than you do when you do an ASO or an anti-strep DNase B if that's just an old titer, old antibody present, or if it actually has something to do with this episode, unless you catch a rising titer. So the D817, the HLA subtypes, would provide us with a trait marker of this is a child who's going to be vulnerable to this happening, which then when we saw that positive antibody, we'd know how to interpret its meaning. Host susceptibility is probably not just genetic. There has to be some reason that this happens so often in children who are 4 to 8 years of age. Is it just because that's the first or second time they're seeing strep, or is there actually something about the developing brain that at that point in time the basal ganglia are more vulnerable? In acute rheumatic fever and Sydenham chorea, we know that there's genetic factors at play because only 1 in 20 families is vulnerable. It appears the same is true in pandas, and this is a good opportunity to clear up a myth that's been making me crazy recently, and that is if you have a family history of OCD or Tourette's, you can't have pandas. You've got, quote, genetic OCD tics. No, our early family studies showed that you actually had increased rates of Sydenham chorea and rheumatic fever and of OCD and tics. So a family history is actually contributory and not an exclusion factor. It appears, in fact, that it may be a dual vulnerability, and we've been tempted to speculate that maybe these children would have ended up with OCD as adolescents or after a psychosocial stressor or in some other fashion as their life unfolded, but they got it early and acutely because they also had that vulnerability to a post-streptococcal reactivity. So the laboratory evidence, I'm not even going to go here. Can you guys all tell me only look for rising titers? But if I hear from any of you who are here that you just checked a titer and you were worried about it not coming down, I'm going to smack your hand, so you've been warned. It is important, though, to remind you that the reason that I'm such a soapbox fanatic about that point is that strep is the occupational disease of the grade school age child. If your child is in elementary school, particularly in the early elementary years, They are the exception if they don't have a strep infection at some point during the school year. So finding strep in a child is common and could be, like Lyme, a true unrelated finding. That was one of the reasons why the first description of this required children to have had 2 strep-triggered episodes, because we wanted to make sure it wasn't just a spurious finding. Normal titers for grade school age children are 440. That's approximately 2 to 4-fold titer rise above what is a negative titer. And this is where Dr. Kaplan and perhaps Dr. Cunningham, but definitely me, will have a disagreement, because he said that since that's normal titer, a child needs to have something higher than that to be of concern. No, it just means that a normal titer for a child is an indication that strep is constantly present and that they've been infected with it at some point in the past 6 to 12 months. 440 is a positive titer, and you still need to be able to demonstrate a 2-fold rise from that. The final thing is that treating titers is absolutely unforgivable, because there's nothing we can do short of plasmapheresis or perhaps IVIG to decrease your titers, and they just mean that you've had an infection before. An ASO is not in and of itself harmful. If it was, 75% of our kids would have problems. And they can stay positive for a really long time. We followed children forward and measured their blood and throat cultures every month for 3 years, and had one child who stayed at 1 to 1960 for his anti-DNA speed the entire study period, despite having no strep. The final piece we talked about a little bit during the Q&A, and that was this question of carrier states. Is one of the criticisms of the PANDAS subgroup is that, oh, you've just found a carrier. And my response to that is I have a 95% chance of not having found a carrier, and I would prefer to treat the positive culture and determine what the impact of that is, as well as to then check and see if it actually was a carrier by doing another culture at the end of treatment. All right, so we're back to the same slide, and by now you guys could say this better than me. Treat and prevent infections. We didn't actually share the prophylaxis data today. Perhaps it's something we could talk about in the Q&A. The data are spotty at best, and one of the difficulties is that it's really hard to implement a placebo control that's long enough to get this in a large enough group of patients. And so what I think the strongest data are actually from our azithromycin penicillin study, where by effectively eradicating strep infections for those children, we reduced symptomatic months and reduced the number of exacerbations from 2 per year down to 0.75. You want to treat the immune disturbance. We've talked a lot about how to do that, and treat the symptoms. And with that, I think it's actually the perfect segue into the rest of the afternoon, because now you know that you might want to think about antibiotics, you might want to think about nonsteroidal anti-inflammatories, steroids, IVIG, plasmapheresis, depending on how ill the children are. But the real treatment ends up being CBT and the psychotropic medications. And with that, with a sort of full court press of doing everything that you can for these children, PANDAS is probably a semi-acute illness. I was asked by a number of parents during the break what's going to happen. I can tell you that we've looked at both our population of children with Sydenham chorea, as well as children with PANDAS who participated in our trials. And for the most part, they're doing so much better than garden variety OCD, which tends to be able to have symptoms suppressed with medications, with cognitive behavior therapy, but the sort of obsessional thoughts are running in the back of their head all the time. They're just not impairing their function anymore. Our kids don't even have them. So this is not a lifelong sentence of mental illness, and it's not something to be terribly afraid of. Those who have continued symptoms, they're imminently manageable with common and well-recognized treatment. One of the things we also talked about during break was what about the sort of cognitive changes, visual spatial skills, executive functions, and all the rest. And for that, I really recommend an IEP, and the parents who are staying on for tomorrow's session are going to hear about exactly what to advocate for, but the most important thing is actually getting a good neuropsychologist to evaluate your child and really identify where those deficits lie. On the other hand, our parents tend to have PTSD. So the interesting thing out of this most recent cohort, now knowing sort of more what was going on with these kids, was the fact that the children tend to have pretty good amnesia for the event, perhaps another evidence that it's autoimmune encephalitis. They don't remember how sick they were. Their parents are scared to death. So parents, get yourselves into some treatment to deal with that sort of fear that it's going to come back, fear that it's going to be as bad as it was, because I can tell you that it's probably not. Resources, this time I really highlighted the PANDAS Physician Network. For the clinicians in the audience, this is a great, great, great resource. Tanya Murphy and I were among a committee that wrote the guidelines, they're not guidelines, suggestions on that website. The PANS Research Consortium is working on formal guidelines, but until those are published, this will serve as a very good starting point for thinking about how to approach a child who has mild symptoms. Bottom line, do nothing. Mild, bordering into moderate symptoms, certainly do nothing after the workup. I apologize. Yes, you want to make sure they don't have strep. Moderate symptoms, most of the time you can wait it out. But for the child who's missing school, or it's very difficult to get to school, or they meet full criteria for OCD, then you have to approach that three-pronged approach we talked about. And we also provide guidelines on that website for how to approach this severely or acutely ill child. So with that, I'll close. Thank you.
Yes, the hardest working member of the panel, Dr. Swedo. So,
they're going to be so tired of me.
not at all. I think you're going to be, there's plenty of questions left, I'm
Okay.
sure. So, I have a few questions left over, and before we start, I'd like to just point out that tomorrow, at the end of the session, there's going to be a young adult panel of people who went through the process of having the PANDAS and are recovered, to talk about what their experiences are. Mm-hmm. And so please come up with questions for them so that they have a chance to consider them before tomorrow. There's over on the floor over there, there's a place to put those questions. And for now, if you have additional questions for Dr. Swedo, we can bring them up. And while we're waiting, I'll start out with this one. Is there a clinical difference between PANDAS and non-group A strep PITANs that we need to know about that distinguishes the two conditions?
I wish there was. There is not. So if we go back to that first or second slide, all of these acute onset disorders look the same. And it really is sort of a dividing point where they present with PANS or CANS. The pediatrics and experimental therapeutics articles are just beautiful agreement on what the clinical presentation of these patients are. Little bit of disagreement on how much we know about what to do once you've considered that differential diagnosis. But the first thing to do is to try and decide if there's an infectious trigger. I think I shared this morning that 80% of the patients who have an adequate assessment, we find strep as a trigger, at least of the first episode of their acute onset. So the vast majority are going to be PANS, and those who are presenting after Coxsackie, I heard about, mycoplasma possibly, influenza, varicella. It's not clear whether those are primary responses to those infectious agents or whether they actually just represent a nonspecific immune trigger after a sensitization to strep.
If it's the case that Sydenham's, chorea, and PANDAS track so well both serologically and epidemiologically, why do we not see, this is the classic question, why do we not see the carditis that comes along with, or rheumatic heart disease that comes along with Sydenham's?
Yeah, so I think the best answer to that is the fact that even when rheumatic fever was endemic in this country and other places, the rates of carditis among patients presenting with Sydenham chorea varied from about 20% up to 80%. So my best guess is it has something to do with the offending strep organism and what the cross-reactive antibodies are. We do know from Stolerman, Taranta and Stolerman wrote a lovely book that I have on my bookshelf about rheumatic fever and Sydenham chorea, that obsessive-compulsive symptomatology was just as common as we had seen in our studies at the NIMH. And in fact, Dr. Stolerman called me to say, you know, Sue, you were right. We forgot about that. Well, he goes, actually, we were so busy trying to keep the kids alive, we didn't care that they were dragging a stool over to the sink to try and get up and wash their hands.
Have there been examples of rheumatic heart disease in patients that had been diagnosed with PANDAS?
There have been, but we did a large study looking at echocardiographic changes in our patients and did not find them. And it's in striking contrast to our long-term follow-up of the Sydenham chorea. So both groups came back to the NIMH. The PANDAS patients, echoes were perfectly clear. The Sydenham chorea, even if they hadn't had evidence of rheumatic carditis at initial presentation, over 50% of them had evidence of cardiac damage at follow-up.
Should the Pneumovax 23 vaccination, or really in general vaccinations, be considered in children with PANDAS as a means of preventing flare-ups?
Maybe I'll let Dr. Cooperstock jump up and answer this, but I'll tell you my experience with influenza.
He may have asked that question, actually. So did you ask that?
I can't actually speak to Pneumovax. Yeah, that's right. So I'll answer for influenza vaccine because that's the one that we are quite bullish on. We insist that our kids have a flu vaccine every fall because they have such a great chance of getting the flu if you don't protect them. Well, this past year, because the CDC blew it, they had a great chance of getting the flu even if they did get the vaccine. But the vaccine is a predictable flare that you can get the shot on a Friday afternoon. I don't know if it's witchcraft or it's reality, but in my experience, sort of anticipating that vaccine and pre-treating with some ibuprofen for 3 days, give the vaccine and keep the ibuprofen up for 3 subsequent days, we've never had a child have a problem. As opposed to the few that didn't get the vaccine, ended up with influenza and had a horrific exacerbation. So I don't know about Pneumovax, but maybe we can talk about that later. Yes, that's right. The entire contact should be prophylaxed. It should be vaccinated. Prophylaxis is not necessary for anybody but your patient, but you do want to make sure that the entire family is strep-free if you're going to be trying to maintain your patient.
So along these same lines about anticipatory approaches to patients, what agents are recommended for ongoing prophylaxis? And along those lines, duration of treatment, months, years, et cetera?
Okay, so this one's a little trickier because we don't have rheumatic heart disease as a sequelae in our group of patients with PANDAS. My best experience has been with families in whom long-term prophylaxis was used until the child got out of the age at risk, which typically was beginning of high school. So by then they've learned not to share drinks, they're not getting in a pile with their cousins at Christmas time and sharing all the germs, and they have much, much less exposure in school. But then they have to actually start again when they finish, if they're going off to college or going into boot camp. Remember, it was the boot camp studies that showed us rheumatic fever, and that freshman exposure to mono and strep can be quite disastrous for our kids. So long-term means not lifetime, but really, really, really long-term. So before you make a decision to prophylax, you have to really be very confident this was strep triggered, because it's the only thing we can prophylax against, and be willing to maintain it for a long period of time. You use the same things as are used in the American Heart Association guidelines for prophylaxis for patients with rheumatic fever. So it's PEN-VK at 250 milligrams every 12 hours. Recognizing the half-life of PEN-VK is so short, you're sort of always at a minimally effective dose, and you don't want to miss a dose. For our grade school age kids, if they miss the dose on Monday morning because your house is chaotic, we know they're not protected for the next 5 half-lives. So that's Wednesday afternoon. Wednesday afternoon, Thursday, and basically you're not providing prophylaxis. You don't want to get obsessive about this, but you need to be careful. Probably a better strategy, and forgive me if I'm going on too long, but a better strategy is actually to go back to what they did in the 1950s before they knew how effective chronic administration of antibiotics could be. There's a beautiful study showing that surveillance throat cultures and treatment as soon as positive was as effective as chronic administration of antibiotics. So for families like the index case I told you about, where the mom knew that if the child's tics exacerbated, she'd do a throat culture, treated it, everything calmed down. You can do the same with your PANDAS patients. Just monitoring, and it isn't enough in that case to culture the child, because exposure to a sibling is also sufficient to cause an exacerbation.
Some aspirational questions. When do you plan to open enrollment for your new IVIG versus PLEX versus waitlist placebo trial, and what will be the ends for each group?
That's a great question, and the opening depends on our IRB, which the NIH has the worst IRB in the entire country. Not worst, best. Slowest, most anal, no. They're extremely difficult. It took us 6 months to get the first IVIG trial through IRB, and then another 4 months to get it through the Yale IRB. So I can't even begin to answer that question, but I promise you we're going to do it as quickly as possible. And we actually have a little bit better hope for the open label look at sort of longer term issues. And so just keep watching the NIMH website. We'll put it up as soon as our clinical trial is approved. You can find out on clinicaltrials.gov. And also the PANDAS network provides you with constant updates on what we're doing in others.
Will you please still publish the other recent IVIG trial that showed greater than 8% response at 12 weeks?
Yes.
I think the implication is that this will help with the insurance coverage for IVIG.
Yes, we will absolutely publish that. The only reason it isn't already out is the editors and reviewers didn't like our first submission. So we're working on the revisions right now, and it probably would have gone back out, but Kyle Williams has to write his dissertation before he can do the revisions of our paper.
And from the same questioner, and I'll link it to one of the parents' questions, can you please comment on plasmapheresis versus PLEX and IVIG as modes of treatment? And the question from the parent was, why reserve plasma exchange for just the life-threatening versions? Why that threshold?
So if I ran the world, plasmapheresis would be the treatment of choice for all children who are impaired enough to be missing school and just really debilitated with this illness. I wouldn't reserve it just for those who are life-threateningly ill. But the reality is the number of pediatric apheresis centers in this country is minimal. There are not very many, and you do not want to have this procedure done someplace that doesn't do it all the time with kids.
But perhaps just sort of have a verbal picture of what the procedure looks like.
Sure. So to do plasmapheresis, which is, our kids called it the blood cleaning procedure, makes good sense. What you do is you put a large bore IV in one arm and a large bore IV in the other arm, and you literally take the blood out for a spin. That's the apheresis team's joke, not mine. But the blood comes out, it goes into a centrifuge, it's spun, and the formed elements, red cells, white cells, and platelets, are returned to the child in a saline albumin solution, and the plasma is taken off, okay? Not so bad. And the boy with the amazing shrinking caudate, he actually was able to do it because he was a gymnast with peripheral lines in his arms. For 90% of the kids who have to have this done for PANDAS, they're too little to do it peripherally, and they have to have a central line placed. Central line placement, if you've ever had to consent for a central line, is probably one of the most frightening things we do, because right at the top it says risk of death. Anything that has risk of death to me is a big deal, besides which most of the children have to be sedated or at least have some anxiolytic medications given. It's done in the ICU, if not the surgical suite. It's a big deal to get that central line in. Then they have to go to the blood bank every other day. Oh, and we did them in the neck. I kept pointing at the neck, but at Georgetown they actually use groin lines because they think they're safer, but that means that the child has to lay in bed basically for the next 7 days until it's done. And they go down to the blood bank every other day. They get hooked up to the apheresis machine. It takes about 2 hours to process a single volume of blood. And then they go back upstairs and they just wait and wait for the next treatment. You do that 5 times over the course of a 10-day period, and you removed 90 to 95% of the circulating antibodies. Wonderful, wonderful treatment for an antibody-mediated disorder. But just going through the plastic tubing activates cytokines and chemokines. It actually could have many, many, many different mechanisms of action that we can't even begin to guess. And as you can imagine, putting a child in the hospital for 8 days versus 2 days of outpatient infusion for IVIG, that's just the reality of what's happened. Sort of a follow-up to that question, if I ran the world, would I use plasmapheresis? Because if you use aseptic technique and don't have a pharmacy error that ends up with a contaminated albumin bottle, as we did in one of our patients with Sydenham, Korea, where we actually gave her gram-negative bacteria as part of her apheresis treatment. But assuming that didn't happen, apheresis, even with central line infusion, ends up being a relatively simple procedure. Intravenous immunoglobulin is a pooled human donor product. The immunoglobulins are harvested from up to 20,000 blood donors, and then those little components are put together. I was talking to somebody, most pediatricians and pediatric centers use the Talocris Grifols product because it's gone through extra steps, including centrifugation, that gives you a very pure IVIG product. But you can't prevent transmission of occult infections. And again, in our Sydenham Korea treatment trial, GammaGuard, which was the IVIG product we were using at the time, had 1 lot of contaminated product, and we gave one of our boys hepatitis C. So I am just acutely aware of the fact that you don't want to trade a semi-acute illness where the child can get better on their own and you could do supportive care to get them through this period for a lifelong illness. Now did I scare you enough? Nobody's going to sign up for our IVIG and plasmapheresis trial. Yeah, that's kind of why it takes us 1,200 screenings to get 40 patients into our study. But
how should we reconcile clinical application of workup and treatment of pandas and group A strep in light of the results of studies like Leckman et al. 2011, which showed no difference between pandas and tick OCD symptoms relevant to the pandas with regard to actual strep infections? How do we
reconcile
that?
Yeah, how do we handle that? So the simplest thing would have been if we had been recording Jim Leckman's talk at the Pediatric Academic Society meetings in 2013, where he admitted that once he knew what pandas was, that it became clear that those kids didn't have pandas. And I could fight with Roger Curlin probably for the rest of my life about whether or not those patients had pandas. I do know that I was present at the time when the admission criteria for that study were being defined, and he refused to use acute onset or exacerbation as a criterion. It just depended on episodicity. His interpretation of the results of that study are actually quite different than mine. And when you look and read the methodology, 2 things stand out. One, every single patient in the Leckman-Curlin study had monthly throat cultures done, and the results were reported to the local pediatricians who have an obligation to treat. So I've just told you that it's a very effective strategy to do monthly surveillance throat cultures and treat when positive. That's what happened in that study. And they were, quote, surprised at the low rates of strep and the low rates of exacerbation in that trial. But when you compare their numbers with the numbers we saw in our azithromycin penicillin trial, they're exactly the same. They had 0.7 exacerbations per child during the 2 years prospective study, and we had 0.78 during the 1 year prospective study. So I think that the results are actually more comparable than they are disparate. And my advice is to be very, very, very careful about the history. And parents, don't exaggerate. You've already heard today why it doesn't help to try and seek a diagnosis of pandas if that's not what your child has going on. Secondly, the comorbidity is really the key here. So if you have a child who presents with acute tic disorder, it's probably an acute onset tic disorder. But if they also have separation anxiety and new onset of bedwetting or new onset of insomnia, they have obsessive compulsive symptomatology, and they meet criteria for PANS, then proceed down that avenue of trying to find out if strep was the trigger.
So the message, I think, is very clear. The diagnostic criteria are important, and that's in neurology and psychiatry, because we often don't have diagnostic tests. We do rely on these for understanding our diagnoses. And in this scenario, it's particularly important that your argument is that that failure to abide by diagnostic criteria has sullied the interpretation of the existing literature.
Yep.
But it's also a problem on the clinical front where
Kind of hanging out there.
Exactly. One of the questions that has come up is how much longitudinal examination of patient cohorts. So there's that first 50 from the 1998 study. They're adults. How much tracking are you doing longitudinally? Do patients outgrow it? Do they regress to the mean, sort of garden variety OCD as adults, for example? Are they more susceptible to having clinical flare-ups? Those sorts of questions.
Yes, yes, yes. So we followed up on all patients that were willing to talk to us, which was many, and actually the vast majority for the kids who participated in the treatment trial, and much fewer for those who were in the antibiotic trials, and that kind of makes sense. We were certainly very invested and best buds with all of our families who go through a treatment trial with us as a virtue of their participation in the study. From that group, those were the data that I shared with you, that the long-term outcome of this group of patients is actually quite good. And that the number who have to remain on anti-obsessional medications or who have failed courses of CBT is minimal. I'll share a story that one of my patients told me. She came up to me at the Rhode Island meeting and she said, she introduced herself, and I kind of looked at her, yes, nice to meet you. And she said, you don't remember me? And I'm like, no. And she said, well, you treated me when I was 8. I was like, you're 30. You don't look the same as you did then. But I did recognize her mom, who hadn't changed as much. And what she told me was that she had hated me at the time for making her get CBT, because she thought it was very difficult to do and just didn't seem to be worthwhile. But it was actually, in her words, the very best thing anybody had ever done for her, because it ended up not only giving her the tools to prevent the sort of mini episodes that will happen for a long period of time in our Kids with Pandas life, but it also taught her the tools that she used for performance anxiety on her tests and for trying to deal with other problems. So again, full court press, treating the infections and prophylaxing where appropriate, treating with immunomodulatory treatments when you have evidence of autoimmunity, and most importantly, treating the symptoms with our standard therapies.
And unless somebody comes running up with another question, we may have saturated the questions. Got one more. Anybody running up? No? Okay, so
Thank you.
We've talked about sleep disturbances in patients with PANS. Typically, it's disrupted sleep, but do you have examples of hypersomnia?
Yes, I would say it's no more than 1% to 2% of our patients. It's really a very unusual symptom, and in both of those patients, they had significant sensory sensitivities, and probably if we were to assess them now, we would be looking at a broader panoply of autoimmune antibodies. Which reminds me to mention the fact that in our PANDAS cohort, we did von der Leyen's panel at the Mayo Clinic looking for paraneoplastic and the autoimmune encephalitic antibodies, and 5 of the 42 children had one of those antibodies in their serum, none in the CSF. So it may be that those may also be additional markers that we can use.
Okay. Any other questions? Do we think Dr. Swedo has done a great job? Thank you very much. Okay, we have a break, and let's come back at 2:15.